So welcome to a segment on Interpace, or molecular testing for pancreatic cystic neoplasm. I'd like to introduce Dr. Paul Corc. We're going to start by asking him what it is. What is molecular testing and pancreagen mean or do?
Well, first off, pancreas cysts are really common, and we see that a lot in our EUS practice. So we need a way to determine which ones are risky and which ones are not. So Interpace or pancreagen molecular testing allows us to risk stratify. We can check for GNAS and KRAS mutations, loss of heterozygosity, and the company does it all with including a CEA level. So we get a nice summary.
Very good. So do you send the test at the time of endoscopy? Do you send it after, when you get all your other results back? Or when would you look at sending the test out from a pancreatic cyst FNA?
I try to tailor it because, I'd like to send it in everybody if possible, but we do want to consider cost and what kind of cyst we're dealing with based on our initial assumptions. But if it looks like an IPMN, which a lot of them are, I may just order it right off the bat. If it looks like a low-risk cyst of some other type, I may wait for the CEA level to come back, and then it gives us the option of ordering the molecular analysis later on. So I find that very helpful. It gives us both ways. And then it can sometimes, in addition to risk stratifying, it can help us with the diagnosis, what type of cyst, because sometimes we're not sure if it might be a serous cyst, but then we do see a KRAS mutation in the result. So that's also helpful for those initially indeterminate cysts.
What does GNAS mean when it's run and when it comes back? Well, how do you play that particular one in your algorithm for management?
In general, the cysts that have more mutations can be higher risk for progression to malignancy. GNAS is thought to be specific to branch duct IPMN as opposed to mucinous cystic neoplasm. But ultimately, either of those are the ones that we need to follow and or think about surgery if they have some high-risk features.
So when you're sitting with a patient and you have this result, and when you're not having this result, is the discussion different? Does it help you in managing these patients?
Yeah, that's a great question, and that simply put, that may be the best reason for this testing, because I'm holding up this paper and we get this really nice summary, and if we can show them this green, which is a benign result, or the statistically indolent, then they really, at 5 to even 8 years of follow-up, the chance of the cyst staying benign is 97% or higher. So it can be really reassuring. And if they do come back higher risk, it doesn't mean we have to sound the alarm, but we have better information to tell the patient.
So we know the data that's out there in your practice, and I know you have thousands of patients with pancreatic cysts. Have you seen the result collaborate, or does it verify what you were diagnosed with initially? Do the patients end up having benign disease 10 years out when you diagnose them with benign disease?
For the most part, yeah. It's been very helpful in that way. We can do a less aggressive surveillance strategy. I've also used it in older patients who come in with a pancreas cyst, and I think I myself in the past might have argued, well, we want to do less testing and spend less money for this older patient who might not be a good surgical candidate anyways, but adding this test can then really reassure us, because then we can tell that patient you really don't need to do more studies and more invasive procedures down the road. And then obviously for younger patients who might have to live with that cyst for many years, it's also very reassuring.
How about the other end of the spectrum, where you have positive findings, high risk, and they go through surgery and you get the specimen? Do you always say, oh, I'm so glad I took the lesion out, or are there instances where you say, I should have left it alone based on the findings of molecular testing?
Yeah, I think we run into both scenarios. So I think that's where, you know, we have to interpret the test as best as possible and the patient's overall health and the risk of the cyst based on what we see in other ways, you know, the appearance, the growth over time if we're watching them for a while. But I have seen several cysts that had a higher risk molecular analysis summary and went to surgery, and they did have dysplasia, even high grade, in the cyst. So I think those were definite wins for going to surgery and getting that treated more aggressively. And I think even the ones that didn't have dysplasia, you could still argue that they probably would have in a few years. So I think it's still helpful, and you know, when we're trying to decide on this tough decision of surgery or not.
Very nice. That's a very good discussion. Thank you so much.